Thank you. I'm really glad that I feel passionate about this topic because presenting at the end of the day, it's nice to be able to keep the energy up for something you feel really strongly about. So in full disclosure, 5 years ago, I knew very little about this topic, but I've learned a lot since then. We've treated a lot of patients, and it's honestly the most rewarding part of my job. You know, you rarely get to cure chronic conditions. That really never happens to us or be able to prevent them. And so we're really excited to be able to share this with you all today. And the need for these services really grew out of our substance use disorder treatments that we were doing. And we realized that a lot of those folks have comorbid hepatitis C or they're at risk for HIV. And so being able to provide these services in our clinic has been great for us and for our patients. So today, just to tell you what we're going to go through, the first part, we're just going to talk about who's at risk. So if you want to target the most likely patients to be at risk for Hep C or HIV, what does that look like? And then if you want to treat them, what is the necessary workup that's required? How do you choose those therapies based on patient-specific factors? And then what does the follow-up look like? And then ultimately, our real goal is that all of you will go back to your current practices and be able to implement what we're talking about to have these services. So if you leave our presentation and you are inspired to start treating people for Hep C or providing PrEP services, we consider that a win.
Great, thanks, Rebecca. So my name is Shukla, as Dr. McEwen introduced us, and I know they saved the best for last, and we have the most energy. So I think there's going to be a voting of who should stay on or off the island by the end of this. So keep an eye out for that poll. So as Rebecca said, our goal here is for everyone to get some kind of exposure to this material. I know there's a variety of participants, and so whether or not you think you'll be providing PrEP or Hep C treatment, I think it's important for anyone, whether a policymaker or a pharmacist or harm reduction worker, to know how effective and easy to use these treatments are. And so, as Rebecca said, this is particularly important for people working with addiction because HIV and hepatitis C are thought to be a syndemic alongside the opioid overdose crisis hitting the United States. So as we've seen this crisis increase over the past decade or so, we've seen the incidence of new Hep C infections increase alongside that. This has been particularly acute amongst younger populations. So those of you who are doing primary care or similar things know that there had been a recommendation from the USPSTF to test all folks known as baby boomers or the birth cohort for hepatitis C, and that's people born between 1945 and 1965. And that's because prior to the opioid epidemic, they accounted for about 3/4 of all Hep C prevalence in the United States. But this has been changing in the past 10 years with this rise of injection drug use across the country, and that now individuals aged 18 to 29 have had a dramatic increase in their both admissions for opioid injection and sequelae of that, as well as Hep C new infections. And so now we're at the point that almost the majority of folks with Hep C in America don't know they have it. And as you can imagine, not only does this affect that person's individual care, but it involves community health and reducing risk of transmission to others. So the way Hep C works, for those of you new to this, is that it's a slow burning infection. It starts with initial inflammation from the infection, which develops into chronic fatty liver disease. And that can take decades to develop. But over time, you have more and more fibrosis, which is scar tissue in the liver cells, until after about 20 to 30 years on average, you have cirrhosis. And so through most of this process, there is little symptomatology or other signs of illness. But the reason we're focusing on this is because it's almost been, let's see, about 9 or 10 years that Hep C has actually overtaken other commonly thought of as severe infections like HIV and tuberculosis. They've been overtaken by hepatitis C as a cause of death. And so the latest data is showing that it's been smoldering at the same level of deaths per year in the United States, 20,000. So Hep C really was, until coronavirus, was the leading cause of infectious cause of death in the United States. So pivoting to HIV, HIV has not been linked so closely to infection drug use as the main cause of transmission. It's still significant, but you can see here that male-to-male sexual contact is the leading transmission risk for new infections in the past. Here you got 2010 through 2017 data. But we do see a particular risk for men who have sex with men who also engage in injection drug use or have a sexual contact that engages in injection drug use. So those are particular cohorts at highest risk for HIV infection. And the reason we highlight this is, besides the fact that there's something we can do as clinicians, as harm reduction workers, as policymakers, that we can do to prevent HIV through the use of PrEP. But there's also some really important equity issues. As you can see here, Black, Latino, and Latino patients particularly have had less access to PrEP care, less conversations with their primary care providers, more barriers to accessing this care, even though they account for a significant portion of people who would benefit from PrEP. And so this graphic from the CDC shows that even though 44% of people that could benefit from PrEP are African American and 25% are Latinx, they account for a very tiny percent of those who are offered and are prescribed PrEP. And so there's a great disparity here between these populations, even though Black, especially young Black men who have sex with men, have some of the highest risks for HIV. And so besides the fact that patients aren't getting enough access to this medication, providers are in general undereducated or underexposed to information about PrEP, which hopefully we're improving that here. But as you can see, 1 in 3 primary care providers and nurses have not even heard about PrEP, even though PrEP itself can reduce HIV transmission, sexual transmission by 90% and 70% for people who are injecting drugs. So I'm going to touch on, we're going to start with hepatitis C. And again, this is really meant to be practical knowledge. We anticipate we'll be done with a lot of time for questions because Rebecca and I do this content with a lot of different learners here at MAHEC and across the region. And so we know that answering questions that are specific to your practice, that's specific to your region and your patient population is the best way to learn how you can implement this in your clinic. And so besides the medical information we'll be giving you, we'll also be touching on implementation issues and how to access care for patients who might have otherwise have barriers to that. So who should be screened? As I mentioned earlier, prior to 2020, it was based on risk factors. And one of those risk factors was the year you were born, 1945 to 1965. But between the CDC and the USPSTF and the American Academy of Study of Liver Diseases, there are a variety of risk factors that are pretty obvious. They all kind of reflect transmission risk. So drug use, and they included intranasal drug use as well, because there are some risks with sharing intranasal equipment. Tattoos and body piercings, particularly at places with unregulated tattoo parlor shops. Sex with high-risk partners, any kind of incarceration, because we know the prevalence of that, of Hep C is very high in incarcerated settings, and sexual assault, as well as injection drug use, using shared injection equipment and informal injection drug equipment is very common in incarcerated settings. Transfusions, organ donations before 1992, which is about when the US started screening the drug supply, the blood donor supply and organ supply. The test for Hep C really wasn't established until about that year as well. Long-term HD patients, patients with HIV, children born to Hep C positive mothers. So as we learn from the world of HIV, if you are waiting to test people based on their risk and then needing a conversation about those risks, you're really missing a lot of people for a variety of reasons. Patients may not want to discuss their risk. They might not even be aware of that risk. They might not even have access to providers who are willing to have that conversation. And so based on a lot of data, especially the data showing the increased prevalence and incidence in the younger populations, just I think about a month or two ago, the USPSTF changed their recommendation to say they recommend one-time screening for all US adults age 18 to 79 at least once. And that's basically like a cross section of Americans if you tested everyone, and then you could catch people who had these indolent infections that they were unaware of. But they still advocate for risk-based screening, particularly for men who have sex with men, patients with HIV with ongoing risk factors, people using drugs, particularly injection drugs, as well as needle stick injuries and elevated liver enzymes as part of the workup. So to highlight people who inject drugs, and this has been a very common and persistent misunderstanding of how Hep C works and how Hep C treatment works. And luckily, the AASLD really clarifies this in their guidelines that active drug use is not a reason to withhold treatments. The risks of reinfection may be there, but the risks of transmission of an untreated person outweigh that risk. And so, and studies have shown time and again that people who are injecting drugs, people who are actively drinking alcohol, people who are unhoused can all be successfully treated with Hep C meds and cured, and can reduce transmission risk to others in the community, as well as improve their own health and life expectancy. So the prevalence is particularly high in people who inject drugs. And if you think back to that slide about HIV, about transmission, again, we're talking about hepatitis C here, but though in HIV, men who have sex with men account for the most infections and HIV incidence in America, the prevalence is much, much higher in patients who use injection drugs. So for Hep C and HIV. So for Hep C, 50% of IDU individuals are infected with Hep C, and they account for 70% of new infections. So that accounts for why they should have at least one test, but really be tested annually while they're at risk. And it should really be provided in an opt-out community-based setting so that you're not stigmatizing people, whether it's in the ER or in clinics or in harm reduction scenarios or even health departments. So I'm going to give the simple version of this slide because it's very simple. You test for hepatitis C with the antibody. If it's negative, you're good. And that's the simple version. So I'll do the less simple version in a second. But if you're positive, that's only showing that this person has had exposure to Hep C. So they might have been treated and cured in the past. They might have spontaneously resolved from their infection, which happens on average to 20% of individuals who get Hep C. So to confirm the infection, the next step is doing an RNA test. Many labs now provide for reflex testing. So you get an antibody, they automatically reflex it to the viral load, the RNA. And so if that's positive, that indicates current infection. And if it's negative, that shows that they either spontaneously resolved or were treated and cured in the past. So the caveats to make it slightly more complicated is that antibody can take months to turn positive if someone had an acute exposure, and the viral load even can take weeks, maybe up to a month to turn positive if someone had an acute exposure. So if you are particularly worried about someone, for instance, someone who had elevated LFTs and engages in injection drug use and shares injection equipment, you might test that person initially with a viral load, not in an antibody. And if it's negative, you might think about testing that person again in a month. So I want you to think, and the way I think about this presentation and how I approach patients is, what are you doing with the patient in front of you? And so I think of, and Rebecca and I have designed our Hep C clinic here at MAHEC along the lines of a specific set of visits, and they're with specific goals. And so the first visit might be after someone's been tested and diagnosed by another provider and they get sent to us. The first visit might be a lot of education about what Hep C is, and then the initial lab workup. And so the initial education I give to all people is sort of the stuff I've told you guys so far, which is this is a virus, it affects your whole body, particularly affects the liver, takes decades to worsen. And so I really focus on risk reduction counseling in case this person ever comes back, or if it takes them a while to come back, in that I liken it to a burning car. That's my metaphor. And so we got a photo of a burning car that, you know, your liver is a car. And if the car's on fire for a day and you put it out rapidly, then you might have a car that's good as new. And so treating Hep C early in an infection instead of waiting for 20 or 30 years is ideal. But if you have a car burning for decades and you put the fire out, it still might be there's not a lot of damage to that car, and the car can drive pretty well. And so putting the fire out is certainly priority number one. But I counsel folks that adding fuel to that fire will hasten the burning of that fire and cause more damage to the car, and thus put it out of commission sooner than later. And so adding fuel to the fire means adding alcohol to your set of risk. And so I counsel all patients to stop if they're able to, or really reduce. And certainly beer is better than liquor, as I tell my patients, and one beer is better than a six-pack. But cessation should be the goal for patients who have that shared decision-making goal with you. Tobacco is implicated in a variety of health conditions, so it certainly affects the liver, but affects other parts of the body as well, and that's part of an overall messaging for all patients. Healthy weight is important. Folks who have obesity or diabetes have higher risk for developing fibrosis and cirrhosis, and then getting another hepatitis will hasten liver disease, so getting Hep A or Hep B, which are both preventable with immunization, should be avoided if possible. And so if we can, when we get those labs, we routinely get Hep A, Hep B serologies, as we'll get into in a second. And then the American College of Immunization Practices, I think, they recommend pneumococcal vaccination for people with cirrhosis. So after I talk to them about how to reduce their own risk, we also touch on how to reduce risk to friends, family, and other people in their community. So that means avoiding ways that you could share blood, and that could be through toothbrushes, sharing toothbrushes, razors, or nail clippers. And though you think that the risk of exposure is very low, we still focus on those things. Really, the most important thing I counsel people is if they do inject drugs, or if they think they might in the future, to use clean injection supplies. And so that's not just syringes and needles, but that's the cotton, that's the water, that's any tubing, because folks will sometimes, and it took me some experience to figure this out, but folks will think, oh, if I'm using a new syringe and needle, I'm fine, but then they might share the spoon or whatever else they're using to cook their drugs, if that's what they're doing. And then we also talk about proper disposal of supplies, and that's important for people with diabetes and other reasons to have needles, to make sure people handling garbage bags are not at exposure. If there is a blood spill, they're counseled to use bleach and water solution to make sure they clean it, and use gloves, especially if someone else is involved. And then sexual activity is sort of a confusing thing, and it's confusing for me as a provider a bit, as well as for patients. I mainly start with saying everyone should use condoms all the time, because you never know what your partner has. Even if you are monogamous, quote unquote, and your partner says the same, you never know. And so I encourage condoms as a basic measure of keeping yourself healthy and safe. But actually, the AASLD does not make a strong recommendation one way or another about condoms, and that's because vaginal sexual transmission is thought to be a very low risk activity for transmitting Hep C, and that's very different from HIV, of course. For anal sex as well, it's particularly men who have sex with men with HIV that are at highest risk, but there hasn't been good studies showing that even with anal sex, not using condoms is a risk factor. But as you know, with other STDs and HIV as well, it's the best thing to prevent infection. So I talked to the patient about ways to prevent transmission, ways to reduce their risk of worsening liver disease, even if they don't get treated. And the patient's like, cool, I want to go forward. I want to get treated. What's the first step? So the first step, as with any good clinician, is getting a good history. This is not a disease process like a lot of things in primary care that manifests with a lot of physical exam findings. And so a lot of it is just getting to know your patient and getting to know where they're coming from. So I often start with how they think they got it and when they think they got it. A lot of times, again, this is getting into stigmatized activities that people aren't really interested in talking to you about, especially if it's their first visit with me. But I explain to them this is really to get at if you have ongoing risk. And so even if they don't volunteer anything, I go through the potential ways someone gets this and the ways to prevent that. So like if you got it from using injection drugs, even if you think you'll never inject again, you should know that the way to prevent this is to using unused syringes and needles. And likewise, the timing. So people will tell me when they first got infected or when they were first told they were infected. And so that might have been last year. But I also ask, so if you were injecting drugs or having sex with men, a man who has sex with men, when's the first and last time you engage in those behaviors? And that gives me a sense of, like, let's say, especially when I worked in New York, I had people who had been tested for Hep C and came positive like a couple years ago, but they said, yeah, the last time I injected drugs was in the 70s or the 80s. So I can guess that person's probably had Hep C for decades. And that really gives me a sense of how much I'm expecting their liver disease to be progressed. So likewise, medical and behavioral health comorbidities is important for all primary care and all addiction care as well. But I pay particular attention to Certain medical conditions, so chronic kidney disease, because your creatinine might affect dosing of certain medications, including Hep C medications. HIV, of course, is important. We'll talk about that in terms of drug interactions, other cause of liver disease. If you are going to be using ribavirin, and this is getting into the kind of next level Hep C care, so we won't go deep into it, you need to know if someone has coronary artery disease or other heart conditions. And the behavioral health conditions are really important to know, just to give proper care and to know where patients are coming from and other barriers they might have. And that kind of links to, on the right side, you see social determinants of health. But oftentimes, you have to manage these behavioral health conditions before you approach the Hep C in order to optimize outcomes. So we'll talk a little bit about that. Med reconciliation, we'll check in a second when Rebecca talks about that. But that's something you want to get in the very beginning, and really focusing on making sure you know over-the-counter and herbal medications. As the review system says there, usually people don't have any complaints. It's a pretty silent infection. We hear that phrase a lot, silent killer. So I'm not going to use that one, but it does usually present only with fatigue. Acute Hep C, on the other hand, which can manifest weeks to months after exposure. I think about half of people get symptoms, and they're usually non-specific. Sometimes there's jaundice and things like that, but a lot of times it's just feeling crummy, fatigue, muscle aches, abdominal pain, usually right upper quadrant pain, nausea, vomiting. So much like acute HIV, people might get it for a couple weeks and then it goes away and they think they just had the flu, and that's what the ER or the primary care doctor told them. And then, like I said, exam is usually benign. So I will focus a little bit on social determinants of health. And again, none of these things, whether medical or behavioral health comorbidity or any of the things you see on the right there, the housing and transportation, none of these are deal breakers. None of these should be thought of as any gatekeeping activity to prevent or allow someone to get treatment. But I like to think of it as optimizing someone for surgery. So as a primary care doc, I do a lot of pre-surgical clearances or pre-surgical assessments. And so Hep C treatment is, you could consider an elective procedure. It can wait. It's, like I said, a slow burning fire. And so if someone has acute housing issues or an untreated substance use disorder, or some other issues that are preventing them from even engaging in care, it might make sense. In fact, it probably makes sense to figure that stuff out first before worrying about the Hep C. And that, in a way, there's not a pill for housing, unfortunately, yet. And so that takes working with your colleagues and in behavioral health and caseworkers, peers, to address those issues. So we've talked about transmission, we've talked about risk reduction, we've talked about their history, kind of understanding their medical history. So what are the labs? So it's pretty straightforward. You get a CBC, and so I'll highlight why we each get one of these, each of these tests. So the main thing about the CBC is the platelet count, and that, along with the LFTs there, feed into some calculators, which we'll show, I think, on the next slide, that help us figure out the level of liver disease. So platelets are like the single, if I had one lab, as I tell my learners and the residents, if I had one lab to kind of understand what's going on with someone's liver, it's the platelet count. And INR is also important for some calculators, particularly the MELD score and Child-Pugh, which I'll touch on in a second. LFTs we just mentioned. Your renal function is important for certain med dosing, but really most of the meds that are effective for Hep C now it doesn't matter where your creatinine is. So you do need a viral load, of course, to confirm infection, and certain payers require that test to be done within a certain amount of time. So North Carolina Medicaid requires it in the last 6 months. The genotype is important depending on the medication you're going to use, and as we'll talk about in a second, that often depends on what the insurer will pay for. But there are several medications now that are what we call pan-genotypic, meaning they are effective, very effective against all genotypes. But just to give you some idea of what this nomenclature means, there are 6 genotypes, at least 6 genotypes, and 4 of them are the most common around the world. And genotype 1 is the most common in the United States, accounting for about 80% of infections. And in the interferon days, and even with the kind of first generation directly acting antivirals, it did matter more what the genotype is. So Hep B, those are the specific tests you should look at. And I see this being done wrong by a variety of providers where they get maybe just the surface antibody or just the antigen. All of them are important. The surface antigen is telling you basically if this person has a level of Hep B active infection. The core antibody shows that they've had evidence of exposure. and then the surface antibody shows if they have immunity. And so this is a little bit tricky. I myself I got a question actually today from a resident about a patient. I had to do some searching on how to interpret some labs. So if you have someone with some Hep B in their system, that might not be the first 1 or 10 patients you're gonna treat for Hep C if you're new to this. HIV is, of course, an important thing to know for a variety of reasons. And then resistance testing is important for certain medications and for certain situations, but it's really going to account for like less than 5% of patients you're going to see. So we won't go too deep into that. And then these meds are approved now actually for kids as young as 3. So they're very effective and safe, but they have not been tested and likely will unlikely be tested in pregnant women. So it's important to know if someone's pregnant before you initiate treatment. So those labs, some of the most important parts of that lab workup is determining someone's liver function. And the reason this is really important is it determines ongoing care you'll do for this person, whether or not they get cured, especially as it relates to screening for a liver cancer, but also might at times determine what medication you use. And so this is one of the tricky places. So everything I've talked about so far is pretty protocol based. You can do it sort of like as a computer. You could just follow the algorithm and it makes sense. Determining fibrosis level up to cirrhosis. So traditionally this has been described in terms of fibrosis stages: F0, F1, F2, F3, and F4. F4 is cirrhosis. And that was based on pathology specimens from biopsies, which is what the previous generation of Hep C care was based on. But now with these great meds, we don't use biopsy to determine fibrosis level because we have this new technologies, which I'm going to talk about in a second here, as well as the need to figure this out to determine if someone gets interferon or not is not as important now that we have these great medications, which we'll touch on. So the first two, and you're at home on a computer and I can't see you, so you can go ahead and look on a different screen at the websites here, but if you just Googled UW, which is University of Washington, and APRI, APRI, that'll bring up the calculator. And so these are simple calculators that the APRI uses a platelet count and the AST, and the FIB4 uses AST, ALT, the patient's age, and their platelet count. And both of those provide you with a score, and then you can see on the website they have interpretation of that score, and it gives you a basic idea of this person's level of fibrosis. These are not perfect tests. They have the sensitivity and specificity on par with other testing, including biopsy, including the things I'm about to talk about, the non-invasive serologic tests here, FibroSure and Fibrometer, and FibroScan. They're all good, but not great. I'm thinking like around 80%, 80 to 85% sensitivity or specificity, but depending on what cutoffs you use. So the approach advocated in the guidelines by the AASLD is to use a variety of these tests, serologic tests, as well as FibroScan if you have access to that, to sort of have a consensus in the testing of what someone is. And if you're still confused or unsure, you should just round up. So if you have a test that's kind of telling you F2, F3, and another test tells you F3, F4, you might kind of lean on F3, F4. So APRI and FIB4 can be done with pretty cheap and easily accessible tests. The FibroSure Fibrometer, there's a couple of different trade names. Those are proprietary tests that use AST, ALT, platelet, but some other serologic markers to give you a score. And again, they're about the same sensitivity and specificity as the APRI and FIB4 to tell you what the level of fibrosis is in this person's liver. Elastography is pretty fancy pants, and I think we have a slide with a little picture of it next, but it's basically an ultrasound, similar to ultrasound technology, but instead of a sound wave, it's the fluid wave passing from one end of the liver to the other, bouncing off the fibrous capsule on the distal end from where you're using the FibroScan. And the speed at which it travels gives you a sense of the density of the liver. As patients have more fibrosis and scarring of their livers get smaller and more dense on average. And so this gives you a predictor of how bad their fibrosis is. Biopsy is very, very rarely done, depending on if you're an academic center that has fellows that need practice, I guess. But in general, we try to avoid it. It has its own false positive and false negative rate, as well as side effects and adverse events like hematomas and infection risk. And it's a gigantic needle. Before, when this was a more common practice, patients would be turned off so much that they didn't want to even engage in treatment because they were so wigged out by the biopsy. So we rarely do that. And then even though you can't use imaging to rule I'm going to mess up my rule in, rule out term, so I won't say it. So you can't use an ultrasound strictly to tell if someone has cirrhosis, but if you do an ultrasound and it shows certain imaging details like nodularity or splenomegaly, or evidence of portal vein hypertension, portal vein thrombosis, things like that, that gives you clues that this person may have cirrhosis. And so there's a picture of a FibroScan machine. There's a, there's a kind of a stand-up version, and then there's this portable version. Medicaid and payers reimburse for it. It's a quick test. It's painless, and it works. In Western North Carolina, I think we only have one machine for all of Western North Carolina, so we don't use it a whole lot. So some other things, and then I think I'm almost close to wrapping up here. But so the reason for those labs, I would say the first reason for all those labs is to determine the fibrosis level, because that's really going to determine their care. You can see where it's starred down there, liver ultrasound every 6 months. So the recommendation from a variety of guidelines, most particularly the AASLD, which I keep mentioning, it's the main guidelines we use in the liver world, says to get liver cancer screening every 6 months for all patients with active Hep C. And advanced fibrosis. So advanced fibrosis is F3 and F4. So not just people with cirrhosis, but also those with F3 disease. And whether or not they get cured or not, you still, so I'm sorry, I misspoke. It's not just people with active disease, it's even folks who have been treated and cured that need that screening for the rest of their life, if they do have F3, F4. So the other things you should do with those labs is if someone is determined to be a person with cirrhosis, you want to do a Child-Pugh and MELD score. The Child-Pugh has been used to determine, the MELD score is used for short-term survival, and it's part of liver transplant workup, and the Child-Pugh is also used for determining where someone falls on a transplant list, and also predicts prognosis in the short and near term. But both of those also give you a sense of if someone's decompensated or not, even if they have not had an event that suggests decompensation, like a variceal bleed. So this is about the point where I say, wow, this is over my head and I should refer this patient to a hepatologist when they have decompensation. There's certain Hep C meds that should not be used in people with decompensated cirrhosis, and they need a higher level of care, even without getting cured. So those are patients you should collaborate with your specialists. And then as opposed to liver cancer screening, which is for F3 and F4, those with F4 cirrhosis are the only ones that are recommended to get upper endoscopy to screen for varices. But as opposed to the liver cancer screening, which you want to know if someone has a mass in their liver before you cure them for Hep C, because it would really change the way they would have treatment available for their cancer. Upper endoscopy can happen before or after treatment for the Hep C cure. So I will stop there and let Rebecca take over.
So when I'm thinking about treating Hep C, as Dr. Shukla's already mentioned, there's a few things that I kind of have in mind. One is, are they co-infected? Just sort of to recap, Hep B, HIV. Do they have cirrhosis? Yes or no? Is it compensated or decompensated? Because that influences our medication decision. And then the other thing, especially since I'm a pharmacist, that I think of is what medications is the patient taking, and thinking through drug interactions, because there are a lot of really common drug interactions. So for instance, how many of your patients take proton pump inhibitors? So things like omeprazole, Prilosec, Nexium, or statins, medications that are used for cholesterol. There are a lot of really significant drug interactions with very common medications. So the first part is just doing a complete medication reconciliation, going through every single medicine the patient's taking, including over-the-counters and herbals, because some of our medications even interact with things like calcium supplements or herbals like ginkgo or St. John's wort. There's a lot of interactions there. And then the nice thing is, these days, a lot of EHRs or electronic systems have access to a fill history. And so I'll try to look at that as well, just to see if there are other medicines maybe the patient forgot to tell us about. And so once I have that list, I always run a drug interaction checker. And the University of Liverpool is based out of the UK, and there's the link here, but it has interaction checkers specifically for Hep C meds and for HIV meds. And it'll tell you, if you click on it, it'll even tell you what to do about it. So for example, some of the medications we use to treat Hep C interact with proton pump inhibitors. So that's something like Prilosec or omeprazole. But that interaction checker will tell you that it's okay if it's omeprazole 20 milligrams taken at the same time with that particular medicine. And so I always do interaction checkers on medications. And then the other part to that is thinking through adherence. So these medications are almost 100% effective, somewhere between 95 and 100%, sort of depending on the genotype, but you have to remember to take them. And so we'll talk more about adherence a little later, but I start asking patients about that in the beginning. What trouble, do you have getting your medicines? What trouble do you have remembering to take them? How often do you miss them? Trying to be very open-ended with my questions and non-judgmental, and then helping them brainstorm solutions that are going to help them to remember them. And then again, like Dr. Shukla said, it's really just this idea of a pre-surgical clearance, but not being a gatekeeper. And we haven't had any patients fail treatment because they weren't adherent. Most patients who come to us, who go through all the steps to get treated, they really want to be cured. And so they're very adherent with their medications. So I tell people this all the time, and I truly mean it. I think the hardest part to treating Hep C is just pronouncing the name of the medicines, right? And so the good news is that the guidelines, if you go to hcvguidelines.org, and that's on our slides later, they give you all the treatment options possible for all the different genotypes. But if you kind of want the easy button or the easy way to do it, there are actually 2 treatment regimens that are pan-genotypic, meaning they cover all the genotypes, and they can be used with cirrhosis or even without cirrhosis. So the first one we'll just talk about without cirrhosis. So glecaprevir, probenecvir, that's the brand name Mavyret, if you've heard of that one. It's one of the newer ones out. You take 3 tablets a day with food at the same time for 8 weeks. The other one is sofosbuvir, velpatasvir. That's the brand name Epclusa, and you take that. That's just 1 tablet once a day for 12 weeks. And so both of those regimens have, like I said, close to 100% efficacy. They're pretty benign as far as side effects, which we're going to talk about. And you can use both of them in patients that have compensated cirrhosis. So again, that's why that fibrosis scoring is really important. And then if they have cirrhosis, figuring out, is it decompensated, is it compensated? Because if it's compensated, you can treat them with the same medications. There's a little bit of a caveat with Epclusa that if a patient has genotype 3, and we actually have this come up quite a bit, especially in our patients who inject drugs, but if they have genotype 3, there's some resistance testing that you need to do. But for the most part, I would just use Mavyret in that patient because it's not required and it's only an 8-week treatment. But those are the 2 most common ones we use. North Carolina Medicaid prefers Mavyret. The biggest interaction I'll tell you with that medication is with ethinyl estradiol. And so if y'all don't know, that's one of the common estrogens that's found in oral contraception. So you have to think through that. Do you use something different like Epclusa or Harvoni, or do you switch them to a different type of like an IUD or a progesterone product? And so that comes up a lot for us because we treat a lot of women who are of childbearing age. So side effects are pretty mild for most people. We've treated close to 200 now, I think, in our clinic, and we haven't had anyone stop because of side effects. But we do talk about them, and then we give patients a list of all the potential side effects and what they can do to help treat those at home, just sort of empower them so they have something to be able to do. So the first is headache. And we actually tell our patients that it's okay to take acetaminophen or Tylenol up to 2,000 milligrams a day. Even in liver disease, that lower dose of Tylenol is safer than an NSAID like ibuprofen, Aleve, naproxen, because of the potential risk for bleeding with those NSAIDs. Other things for headache, bed rest, making sure you're drinking fluids, fatigue. A lot of our patients complain of fatigue if they're able to take naps, if they can get outside and exercise, making sure they're getting good sleep. So a lot of sleep hygiene, limiting caffeine. We can do sleep aids, things like melatonin are fine. And then some patients do complain of nausea, and so thinking through things like ginger or Phenergan or ondansetron. But again, anytime you prescribe something, always checking that Liverpool drug interaction checker.
I was on mute, but now I'm not muted. Okay, so so treatment is pretty straightforward, or I would call it pretty straightforward, as Rebecca showed us. And monitoring is even more straightforward. So I talked about that pre-treatment workup, which is, straightforward, but interpretation can really affect your understanding of the fibrosis of that patient. But once you've done those labs, for the majority of patients, you don't need to get labs until you're testing to see if they're cured, which happens 12 weeks after their last dose. So what is important is checking with the patient, particularly that first week or two, to make sure they're not having side effects and have not stopped medication, or that they are doing good with their adherence. In my, I've probably treated 100, 150 patients. I've only had a few patients that that had side effects that were significant enough for them to stop, and that was in one patient who had really bad gastroparesis from diabetes. So in my experience, very, very rare for side effects to be that bad. And in the clinical trials, it was the same. No one dropped out because of side effects. But so especially in the world of COVID, we're doing a lot more of the telehealth or telephone visits to make sure people are not having any issues and taking their meds. We do touch on a couple issues is because of insulin sensitivity can actually improve when patients are getting their Hep C treated. There can be some hypoglycemia, symptomatic hypoglycemia, particularly in patients on medications that are prone to causing hypoglycemia. So we counsel patients on that and check in on that. And then warfarin is one of those potential drug interactions. If someone's on that, we make sure we're checking their INR more closely those first few weeks to see if they need dosing changes. So especially if you don't have cirrhosis, it's unlikely to need any lab monitoring. But like I said, there are rare situations, particularly patients with cirrhosis or LFT issues that you notice beforehand that make you more worried. You might want to test them 2 or 4 weeks after they start medication to check to see if they have any issues, particularly if they become symptomatic with like nausea or jaundice or something along those lines. So I wanted to make a shout out to Hep B because that's one of the few curveball kind of tricky things. And like I said, even me as a person who's done this for a while, I am hesitant to try to manage a co-infected Hep C, Hep B patient by myself. But if patients do have Hep B, even if they didn't before you engage them, if they did not have a reason for antiviral treatment because their viral load was really low or their LFTs are really low, there has been cases noted across the world that people are having reactivation basically of their Hep B when they're doing Hep C treatment. And the reason for that is pretty complicated and has to do with immune suppression and various things. But basically, if someone does have Hep B surface antigen positive, you should have started treatment either prophylactically or at least with close monitoring before you even consider the Hep C treatment. So I'll just leave it like that. But if we have time at the end, we can delve into that further. So as I mentioned, 12 weeks after they take their last pill, that's what we call SVR12. That's nomenclature from the interferon era, but it means basically you're cured at 12 weeks, and that's as good as gold. You don't need to test them again. I see a lot of providers, even for untreated patients, checking a viral load like every year. You don't need to do that. Once you have a viral load and you know someone's positive, that's that. And then once you've treated them, you check that viral load after 12 weeks of their last pill, and that's that. The only reason you would check a viral load again is if you have a new elevation in their LFTs or some new exposure where you think they were reinfected. And then as I mentioned earlier, if you have cirrhosis, you're still getting those ultrasounds every 6 months, including if you're F3, not just cirrhosis. And then just for cirrhosis, which is F4, you're getting upper endoscopy every 1 to 3 years, depending on what the findings were at the last visit. And then even if you're cured for Hep C, if you have cirrhosis, you should have the same counseling for anyone else with cirrhosis, whether or not you're cured, which is avoiding hepatotoxic drugs, avoiding alcohol, maintaining a healthy weight. So just to touch on special populations, and again, hopefully I'm making the case that this is pretty simple. Pregnancy shouldn't treat people. The risk of vertical transmission is about, studies veer between 5 and 25%, but it's closer to 5 to 10, I would say, transmission from mother to baby. And then once a child is as old as 3 years old, they can do treatment. And because Hep C is a slow burning fire, there's usually not a big rush in kids. As I mentioned earlier, if you have active substance use, it is not a contraindication to treatment. In fact, it's a great reason to treat someone because it reduces the community risk of transmission. And adherence and cure rates are similar to the general population, especially if they're linked in with treatment and harm reduction services. especially if you're co-locating those services. So a primary care doc who's providing buprenorphine, as well as Hep C treatment, as well as PrEP, that's the gold standard, I would say. Hep B co-infection, we mentioned, that's something that you might want to do with the hepatologist the first few times. And HIV co-infection, all the treatment guidelines are the same. You just want to make sure you're aware of potential drug interactions. But cure rates are also great. And just know, and this is present in many counties across North Carolina, but here in West North Carolina, we have a Hep C bridge counseling program, which provides care coordination and addresses barriers to getting care for patients who need it. It addresses insurance issues, transportation issues, even stigma and other issues related to their Hep C diagnosis. And so if you don't have that in your county, it's good to find whoever can provide some of those services, which might be your local harm reduction organization or care management organizations. Oh, and Rebecca, I think I took your thunder on that last slide anyway.
That's totally fine. And I'm gonna hit the highlights because I'm loving all the questions that are coming up in chat. So I do want to make sure that we have time to address those. But there are some common barriers and misconceptions regarding treatment that we hear a lot. One is related to just cost, for instance. And so I can tell you that of all the patients that we've seen, the most I've ever had anyone pay for a Hep C medicine is $5. So I'll tell you how we've been able to do that. Comorbidities such as substance use disorder, one of the questions that I saw in the chat is, well, does North Carolina Medicaid pay if they're active substance users? And actually they will. So in North Carolina, the only criteria is that they have to be abstinent for a year or in a treatment program or receiving counseling. So as part of our intake process, we're counseling them around substance use, around harm reduction. And so we're able to get all of our folks with Medicaid treated because, again, it's a public health thing as well. You know, we're preventing spread of hepatitis C and HIV. So we have been able to get all of our Medicaid patients who are active users treated. And then just competing priorities, loss to follow-up. As you all know, most of these patients have other social determinant of health issues going on, like transportation or childcare. And so I've highlighted each of these sections. The biggest thing is what we've been able to do with co-locating our services. So we offer MAT, we offer mental health services, we have primary care, and now we do have hepatitis C. And the reason we did it is because our local gastroenterology office was so overwhelmed with referrals, and it's really easy to do. And so not only do we treat our patients, but we also take outside referrals. I've seen some conversations about that. So just know that we do take patients and treat them without them becoming primary care. And then the other thing is just lack of practitioner experience. I think people just think that it's intimidating and it's hard. And there is some paperwork, which we'll talk a little bit about. But once you get the hang of it and you develop sort of this network of people who can mentor you through that, it's pretty easy.
So now we'll pivot to PrEP. And thank you, Rebecca. I wasn't really paying attention to the clock, and I can't see the chat box because of the weird screen setup I have. But PrEP is even more simple than Hep C care. So we'll be hopefully going through this pretty quickly and get to those questions. So who qualifies for PrEP? To make it simple, it's really anyone with significant risk. And so the easier one to figure out is someone who's injecting drugs and has an HIV positive partner, or they're otherwise sharing injection equipment. So that's a pretty straightforward thing. If you look at the guidelines on various sources, they make the sexual risk a little bit more complicated. And so we sort of distilled it down to basically someone who's having sex, whether anal or vaginal sex, in the last 6 months, and either their partner is HIV positive known, and that's called serodiscordant partner, or if they've had a recent bacterial STI, which suggests that there is a risk there, or if, and this is the one that's the biggest, kind of the biggest net, if there is inconsistent condom use with their partner. And so it could be any of those. And really, there's a shared decision making, like there's a certain risk in your behavior and a certain reduction at risk with using PrEP with or without condoms. And what's the best thing for you? And so that's the conversation that you would have with your patient. And as this slide notes, it's recommended by the USPSTF. So what are risk behaviors? So this gives you a sense, I'm not gonna read through this slide, but it shows you the relative risk between different risk behaviors. And so getting a transfusion, of course, with someone with HIV positive blood is very, very high risk. But you can see that oral intercourse is actually very, very low. And actually vaginal intercourse is quite low, but anal receptive intercourse is quite high comparatively. So when we see a patient who is either they don't know that they should be recommended PrEP yet because I haven't gotten there yet, or somebody sent them to me to talk about PrEP, we start with sexual health. And in the interest of time, I really want to go through all this because I think it's important to kind of learn how to have those conversations. I think that's probably the harder part of this than the actual medicine. But really, it's about addressing the stigma of certain sexual practices to allow a conversation to happen openly. And so I talk to patients very quickly about, or very directly about, what they're doing, what parts of their bodies, how often, and with a real open-minded, non-judgmental approach. So it's really important to get into the specifics because of that last slide showing that different sexual practices have different risk. We do talk about substance use during sex. Some folks might be familiar with the term chemsex, and that's quite common in certain parts of the countries, particularly urban areas, with men who have sex with men and amphetamine use. And we talk about harm reduction, not just condom use and syringe access, but also things like naloxone for people who do inject drugs. And part of that conversation is safe dating for men who have sex with men who use dating apps, the safety in using those apps and interacting with people who you don't know and may be having sex with later tonight. Those are all important things to talk about once you develop that rapport with your patient. So the things that are needed to prescribe PrEP is knowing someone's HIV status. And so unlike Hep C testing, HIV, the modern fourth generation HIV test can tell you someone's HIV status basically 7 to 10 days prior. So if they had an exposure 4 or 5 days ago, it may not come up in the HIV test, but if it's 2 weeks ago, it will. You should not use oral rapid tests because of their sensitivity and specificity is not as great. And then, yeah, if you're suspicious of an acute HIV infection, you would just skip to the viral load, whether because they have signs and symptoms of acute HIV or they had such a recent exposure. So if someone told me, like, yeah, I was injecting drugs with someone a couple of days ago, I would say, well, before we get PrEP, I'm going to get an HIV viral load rather than the antibody test. You do want to get a renal function because Truvada, which is the main medication we use for PrEP, is not supposed to be used in people with CKD4 or worse. And then Hep B again pops its head into this world, and as you can imagine, Hep B, Hep C, and HIV all travel together and are syndemic. But Hep B is important to know. Somebody's Hep B status is important to know, one, because it's important to vaccinate someone if they're an injection drug user or if they have sex with men who have sex with men, because they can prevent getting that infection if you can identify their risk and the fact that they're not immune. But additionally, Truvada and PrEP medications are effective against hepatitis B, but you want to be sure you know what you're doing before you start that if someone does have Hep B. And I'll leave it like that. I'm leaving a lot of Hep B questions to the side for now. And again, pregnancy testing is important, and part of that is developing a family planning plan with patients to prevent pregnancy if that's what they want in life. But it is safe to use in pregnancy if someone is at risk, and it is safe to use if someone is planning for pregnancy if that is a part of their risk as well.
So the medications for PrEP, there are really two. So the first one, Dr. Shukla has already mentioned, is Truvada. That's the N-tricytamine tenofovir, or the TDF form of tenofovir. So you'll notice Truvada, which is the older one, and Descovy, which is the new one, both contain essentially the same medicines, the N-tricytamine and tenofovir. It's just that the tenofovir component is a little different in each of those. And so I'll explain a little bit what that's about. But these are pills that you take once a day, with or without food. They can be used in adolescents and adults. Anyone that weighs at least 77 pounds, pretty well tolerated, and we'll go over that on the next slide. So Truvada is approved almost for everyone. So that's for men who have sex with men, so for anal sex, for vaginal sex, for injection drug use. That one in particular, you can only use if someone's renal function, their creatinine clearance is greater than 60 mils per minute. And that's because the tenofovir part of the medication can actually cause some renal dysfunction, which we'll talk about in a minute. So this particular medicine, Truvada, had some issues with renal dysfunction. It had some issues with bone mineral density loss. And so what they decided to do, the drug company, they decided to reformulate tenofovir into a different prodrug. So a prodrug is just a drug that your body then converts to the actual drug. And so they made a different prodrug called TAF, and they put that in their new medicine called Descovy. And that one, they market it as it has statistically significant less bone mineral density loss and less issues with renal function. Interestingly, though, it also causes an increase, more of an increase in your LDL, so it affects your cholesterol a little bit. It can affect weight a little bit. And so if you read information about these two drugs, Truvada versus Descovy, the Truvada, well, I'm blanking on the word, but it will be generic this fall. So basically Truvada is going to be generic this fall. So there's been this push by the drug company to switch everybody to Descovy. But in my mind, I think as long as you're being patient-centered and thinking about your patient-specific factors, either one of them are probably fine. And so Descovy, because it is the newer one, it just hasn't been approved yet for vaginal sex or injection drug use. Again, pretty benign medications when you think about old HIV drugs versus the newer ones. Headache, nausea, flatulence, those tend to happen in the first month and they do resolve, and you can use over-the-counter medicines to treat if necessary. Again, thinking back to drug interactions, the University of Liverpool has that interaction checker specifically for these antivirals. And then for them to be the most effective for anal sex, you need to have someone start at 7 days before any risk. And then for vaginal and injection drug use, these medicines aren't as effective, but they're still about 70% effective in preventing that. And you want to start those about 3 weeks before. The other thing that we want to talk about, because it's not FDA approved, is you can do episodic PrEP, or it's called PrEP 211. So for people who have less frequent anal sex and men who have sex with men, you can just sort of use these medicines as needed. And then again, warnings for these medications, they can cause rebound hepatitis B, so we're going to monitor for that, and then acute renal failure, and that's why knowing what someone's renal function is really important.
So once someone started on PrEP, the monitoring is pretty straightforward. And actually, there's one step skipped. It's recommended that at month one of starting PrEP, you check in on adherence. But there's no lab testing happening then. So the first time you're getting labs is at 3 months after initiation, which is from then on, every 3 months, you're checking an HIV test. But that first 3 month period, you're also checking to see if there are any signs of renal dysfunction by checking your creatinine, and checking in if you should be doing any additional testing for other STIs. Really, you're doing that before you start PrEP when you're doing that initial lab workup anyway, but if there's ongoing risk, you want to check in on those. There is some evidence that PrEP is effective at preventing herpes transmission, but not the other STDs. And then, yeah, you're checking on someone's reproductive plan, family planning plan. And then every 3 months after that, like I said, you're checking your HIV, you're checking in on adherence and making sure that you're reducing the risk otherwise. And as needed, you're checking for STDs, and as needed, you're checking in on that reproductive health plan. But otherwise, it's just that from then on. You're checking a creatinine every 6 to 12 months, really, after that. If someone's going to have renal dysfunction, it usually happens in those first months of starting this medication. And after that, usually people are pretty good. But there are cases of sort of a late onset for renal dysfunction in Fanconi. So you want to be checking that regularly.
Okay, so we're going to talk a little bit about med access and adherence, because I think that people feel this is a barrier when it's not really a barrier, it's just a perceived one. So before I go into this chart, I want to let you know the next slide, or you can go ahead and go to the slide, but before I go into the details of this chart, I do want to let you know that the next slide is sort of the easy button of med access. So if this is too much to take in or think about, that's okay. But what I want you to know mostly is that, like I said, our patients have paid at most $5 for these medicines. It's just a matter of knowing the resources. So if you look on the left-hand side in that column, I have the insurance type. And then as you go across the row, there's the type of resource that's available and how much it's going to cost the patient. So for patients who are uninsured, the manufacturers of these medications, mostly Gilead and AbbVie, They make these medications available to those patients. There's a little bit of paperwork to fill out, but you can get them through patient assistance programs and they're free. For patients that have private insurance, they're copay cards. And the way that I find those is once I decide what medicine I'm prescribing. So let's say I'm going to do Mavorite. I go to Google, I type in Mavorite savings card, Mavorite copay card, and it just pops up magically. You give them a little bit of information about the patient, and then there's a $5 copay. They take it to the pharmacy. The pharmacy runs it through as like a secondary insurance, essentially. Medicaid, these are covered. You do have to do a prior authorization, which we'll talk about. And for all of them you do, because the medicines are so expensive, especially for Hep C. And then Medicare, this is the trickiest one. So a lot of times our Medicare population has a high deductible, or they have an 80-20 split for specialty meds. But there are two programs that I want y'all to know about. One is the Patient Assistance Network, and the other one is the Health Well Foundation for Hep C. And they ask the patients, it takes probably about 15 minutes. You can do it online. They ask the patients questions like their social security number, some general questions about income. They verify all of it in the cloud of information, however they do that. And in about 15 minutes, they offer a $30,000 grant that's paid directly to the pharmacy. So we've had patients come back and say, well, it was $4,000 at the pharmacy. Well, we spend 15 minutes, sign them up with one of these programs, and then they're able to actually get it for free. And then HIV PrEP, the great news is that because the United States Preventive Services Task Force has it as a grade A recommendation, it essentially means that insurances have to pay for it. And so our patients should have very low copays for that. And then by 2021, that cost sharing should essentially be gone for almost all of our insurances. All right, so if you don't have time to sit down and think about all those things with your patients, it's totally fine. These drug companies want you to use their medicines, and so you can Google it, or you can keep this list, and the patient can call, you can call, and usually there's a nurse navigator or care management support that will ask them about their insurance status, will ask them about their income, and they'll direct them to all these resources that I've already talked about. So there is sort of this easy button for med access. Again, that should not prevent you from providing these services to any of your patients. And then, medication adherence counseling. Adherence is one of the key parts for these medications. And so like you would do with all your patients, establishing trust, bidirectional communication, making sure that you're non-judgmental, you're open, make things as simple as possible. So if you can do a regimen that takes one pill once a day, I mean, that's ideal. Letting them know what side effects to expect, how to manage those. And then we tell people at every visit, these medications are almost 100% effective, but you have to remember to take them every single day. And our patients are motivated, and they do that, and we reinforce that with them as well. And then supporting that adherence, I try to offer suggestions, but ultimately that patient knows their life better than I do. And so is it a cell phone alarm reminder? Is it putting it beside their toothpaste? Is it putting it, beside their breakfast in their kitchen? Really, what's going to help them remember? And then I try to be open-ended about asking about adherence. So how many doses of your medications have you missed? What trouble are you having, taking your medicine? And I think just being upfront about the efficacy of these medicines and the relationship to adherence and not judgmental has really helped.
So, dearest audience, we are approaching the end, and I really want to get to the slide of the questions. And I know we don't have much time, and everyone's probably waning on their energy. So these next slides are really on coaching you, and this is something we do here at MAHEC for other practices, coaching you on how to implement this in your own practice. So I'll probably go through this quicker than I'd like to, but I will point out that anyone who's in the audience can email me, and I think I can extend that to Rebecca, if you like more information, both clinical or how to get this started at your clinic. Even if you're a single practitioner in a rural practice, you can do this, and you would be really an important part of the community health for if you were that sole practitioner doing it. So one thing is, both for Hep C and HIV, these are stigmatized diseases and stigmatized risk factors. So having a welcoming environment, both for LGBTQ folks as well as people who are using drugs, non-judgmental, curious, open-minded approach, both not just the practitioner or the prescriber, but front desk, back desk, the the nurses, the person doing phlebotomy, all those things are important. And that might be changing your forms for identifying someone's gender. That might be signage in your clinic. That might be doing a training for your staff on equity and stigma. Using technology to work for you. So there's a lot of ways you can have your EMR prompt you to do one-time screening for Hep C and HIV. Now that, especially that these are recommended as a one-time screen for all adults. HIV, it's age 16, I think, to 65, and Hep C is 18 to 79. So you could easily program your EMR to prompt you on that. And then there are various screeners and questionnaires that your medical assistant or nurse can administer before you're in the room that can assess whether this person has risk factors for sexual high-risk activity or drug use. And then, if you're starting from scratch and you want to start a program, pick the patients who are already stable but have high risk. So doing more screening in patients with substance use disorder or opioid use disorder is an easy way to get things started and really making a difference in the individual patient's health as well as the community health. So for Hep C specifically, starting with low-hanging fruit, people with low levels of fibrosis, otherwise medical and behavioral health stability that are adhering to their other medications, those are the ones to start with. You don't want to start with someone with HIV or Hep B, comorbidity, co-infection, or someone with unstable behavioral health issues. There are a variety of modules. University of Washington's great. The guidelines on the AASLD's website and the drug checkers that Rebecca pointed out are great resources. I use them, and I've been doing this for a while, and I still use those. And so you can learn to do this yourself. The modules are really great. You can have them on in the background while you're doing some other things. And then there's other ways to get kind of help as you're doing your first patients, whether it's someone like me, and I invite anyone to email me or call me if you had a question. The UCSF, University of California, San Francisco has a great warm line. I've used it for complicated patients, and usually you can get someone on the phone with you within 20 minutes. And if you've done it once, then they have you register and it's even faster. Working with your local GI, they'd be happy for you to take care of their easier, less complex patients. GIs usually want to do the more complex patients anyway. So, and then North Carolina, for those of you who are joining in North Carolina, the CHAMP program is awesome. You can look it up by going to the website, but they offer free training and mentorship over Hep C. Things to make this more effective, having a registry with important clinical and demographic information, and having somebody kind of keep an eye on that registry will help you track those patients before they're in treatment, while they're on treatment, and then after treatment to make sure you're checking them for SVR12. And having a protocol, which is what we have, EMR quick text, having a one-pager that you can share with other providers as they're learning this can make it all the more easy. And then for PrEP, we talked a little bit about this in the other slides, but really encouraging more liberal offering of this to patients, especially based on the data we saw that Black and Latino patients are less likely to be offered this. And then consider this as part of a broader sexual health and substance use disorder harm reduction framework. And so I'm not going to read all those off because it's very dense, but I would encourage you to look into all those, especially the Using Alone. Neverusealone.com is an awesome website. I've been offering that to a lot of patients in the lockdown we're having from coronavirus, and it's been really helpful for some patients. And then for PrEP especially, I give 3 months refills at a time. I'll give more, but I give 3 months at a time initially. So as a prompt for both the patient and me to make sure the patient comes back for their labs. I think that's all I'll say about that. Oh, Rebecca, this is your slide, sorry.
Yeah, no, that's okay. Getting the medications, like I said, the cost is not the barrier. Sometimes the paperwork is. So especially for Hep C meds, they require pre-authorizations. They're tedious at times. You have to dot your I's and cross your T's. But once you do it a couple of times, it actually becomes really streamlined. And our staff, we actually have an LPN that does that for us. And she can get Medicaid approvals within 24 hours. And she can get private insurance, Medicare, generally within 48 to 72 hours. She's really good at it. And so having someone that has that designated role is a good place to start. For private insurances and Medicare, you can use covermymeds.com, which is a centralized place to be able to do those pre-authorizations. If you deal with Medicaid, the NC Track is where you do those. There is a beneficiary readiness form, and that's where it's asking you about mental health, about substance use disorder. So again, as long as those patients are in some sort of counseling or treatment for those things, then you can treat them even if they're actively using. And then, like we've talked about, for uninsured, there's patient assistance programs. And the last thing I'll say is, because I feel like the pre-authorizations often deter people from doing it, pharmacies make quite a bit of money off of these medications because the medications are thousands and thousands of dollars. And so a lot of them are willing to help you and willing to do the pre-authorizations for you. And so if you have a local pharmacy that you enjoy working with, ask them if they can get these medicines for you. And then as far as specialty pharmacies, I have no affiliation with any of them, but we do work with some Walgreens, one in Charlotte, one in Durham, and they do pre-authorizations for their local providers if they don't have another resource for that. So again, don't let that be your barrier.
Great. And Dr. McEwen, please let us know if we have time for a few questions.
Yeah, we do. A lot of the questions are around access. So I think Rebecca hit that pretty well with a couple of those slides. And also people need to know that all of the presentations are posted on the website, the conference website. So all those links and other information that they left, you can get that under course materials. So yeah, most of the questions were about access, about insurance, that kind of thing. There were some questions about Medicaid and Medicare. I'm not sure, requiring that the patients can't be actively using. But I think you addressed that in terms of they need to be in treatment. So that's not actually a misconception, it sounds like.
Yeah, and I'll point out some states are stricter, and it's an evolving process in state Medicaid boards. So in New York for a while, they were very strict about it, and they've changed. And I'm proud that North Carolina has been more progressive on this, that you can treat people who are actively using. The data on this shows that there's definitely community as well as individual health benefit to treating someone who is actively using. So though there is a tiny risk of reinfection, you're really reducing transmission to others. So always good to treat anyone who's willing to get treated.
And is there a way to find, a centralized way to find treatment providers who will actually take patients with Hep C? If you don't feel comfortable doing it?
Good question. And Rebecca, chime in, but I think you would start with your local GI or hepatologist. In Western North Carolina, if there's anyone in Western North Carolina, you can refer them to MAHEC. I'd be happy. We take everyone. And then if they're medically too complex, we'll send them to our local GI. But do you know, Rebecca, of any?
So there are a couple of resources that I would recommend. If you're in Western North Carolina, we actually have the bridge counselors have a database of everyone who's treating. So I know I saw someone mention Appalachian Mountain Community. They're an FQHC here that treats. Blue Ridge, our FQHC treats. And then if you're not in our area, what I would recommend is actually getting in touch with the CHAMP program, because they know all the providers that have been through their training. And so they're going to know the providers that treat sort of outside the specialty world.
I'll also point out that, coronavirus is a terrible thing, but it's opened some really interesting opportunities. And Rebecca and I have been doing telemedicine. I mean, there's not much physical exam maneuvers that would affect my clinical decision-making. So as long as I can get the person to come in for labs, I can do all the follow-up from telehealth platforms, and it's been great. And patients are actually less likely to no-show when I can just call them up.
Wonderful. A question about the, assessing the Hep C liver damage. At one end, you have the liver function test. At the other, you have the elasticity scanning. How far do you go? How do you know?
Yeah, I would call this one of the most difficult of the clinical decisions you have to make. And it's not much harder than a lot of things we do in medicine, but it is a little sticky because there's not a great yes or no 99% sensitivity specificity test. So the approach advocated in the AASLD guidelines is using more than one test. And if they are concordant, so you do an APRI and a FIB4 and a FibroSure, is kind of what we do. And if they all kind of point south, then you know you're going south. You know this person is either has advanced fibrosis or not. But if they're discordant, meaning one says F3 and the other says F1, then you need a tiebreaker. And so we often use FibroScan for a tiebreaker. And then beyond that, if you're still having discordant results or it's just clinically doesn't make sense, I round up because it's better, I think, especially since ultrasound is a very accurate test for finding a mass and is not invasive. I round up and would rather over ultrasound people than under ultrasound someone.
And you have to send them out for the fibroscan?
We do
They
here
go to a
because
hepatologist for that?
correct. Yeah, we don't have a machine in MAHEC, but
Yeah.
you know, most hospital systems will have it. It's actually, you know, it's like maybe a 5 or 10 minute procedure, and I think reimburses like $60 for Medicaid. So it's not a complicated procedure. We just don't have a machine.
Okay.
And one thing that I'll mention that came up in the questions was around hepatocellular carcinoma. And, you know, do we have patients who have had that even after treatment? So in one of the slides that Dr. Shukla had, if they have F3, so advanced fibrosis or cirrhosis, it's really important to get that ultrasound first to rule out hepatocellular carcinoma, because at MAHEC we've had one treatment failure, and it was because the person had HCC and we didn't catch it before we treated them, and so they weren't able to get cured, and then they had HCC. And so that's really a patient you would want to refer to a specialist if they have that. So that's that importance about the ultrasound in F3 and F4. Again, though, one of the things that we run into occasionally are barriers for our uninsured patients of getting ultrasounds, getting fibroscans. That our bridge counselors have been really helpful in coordinating some of that for us.
Great. I think we have time for one more question, and I think this is one that Dr. Shukla will like. What is medication access for inmates like, or is there any? How is that being addressed?
We're on the same page. That's the question I was highlighting or looking at. So this is complicated because it's a great place to treat things like Hep C, because for better or for worse, mostly for worse, but you have a captive audience. You could do basically directly observed therapy, and the prevalence is really high. So if I were, one day I'll be in charge of everything and I'll make sure we have treatment access in all the jails and prisons. But as you can imagine, if you're incarcerated, you've lost access to Medicaid and Medicare. You've lost access sometimes to private insurance if you had it through your employer. And even if once you're released, oftentimes you've lost these benefits. So the cost of these meds goes to, depending on the system, the county or the state or the feds, you know, if it's a federal penitentiary. And so that's a lot. You know, the sticker price for these drugs are very expensive, though that's, you know, in the American health system, that's sort of an arbitrary price point, but they're very expensive. And so I know, and even like New York City's jail at Rikers Island, they had real difficulty in treating to scale because they just didn't have the capacity to pay for all those meds. So it's a problem still. I think the best thing I could offer is working with the corrections facility to make sure there's a good handoff. And that involves like having peers, reentry councils, FQHCs in the area that can quickly take that patient on, not only to deal with their Hep C, but their likely substance use and mental health issues that come from being incarcerated in the first place. So it's a tough situation. It would be great if we just had the funding to just treat all the people that are incarcerated.
I do
Wonderful.
know that I think it was last year, actually, there was a lawsuit that happened in Tennessee around access to treatment in the prison system. And so CHAMP, the Carolina Academic Mentoring Program that's run through UNC and Duke, they've been proactive about that, and they have been intentionally trying to train providers in the prison and jail systems.